Dr. Bratt, David.
All right, so somebody talk to me.
So as soon as you're ready, you could go ahead.
I can?
Yes, you can go ahead.
All right, I go in 5, 4, 3, 2, 1. A very good evening and welcome to this first episode in a week-long series of discussions organized by the National Contract Workers and General Employees Association of Trinidad and Tobago. The theme for these discussions is Vaccinate to Operate, as it endeavors to take a dispassionate look at the varied issues and challenges surrounding the presence in countries around the world of the coronavirus, so named COVID-19, and how the authorities in this country have sought to treat with the containing its menace over the past 18 months. This evening's episode will kick off the series looking at the general history and purpose of vaccines and the pros and cons of COVID-19 vaccines. And indeed, there are many pros and cons on the issue on the international scene for getting vaccinated, as well as the companion containment measure of wearing masks. Broadly put, to mandate or not, that is a question everywhere, as the vaccine mutates, presenting new challenges for the authorities everywhere. Panelists for this evening's discussion are as follows: Dr. David Bratt, Dr. Joel David Nanton, Dr. Fuad Khan, and Dr. Denise Soyafat Angus. Each panelist will speak for about 15 minutes, and then we'll engage in discussion among them on their presentations, fueled also by questions posted from you in the virtual audience, as well as from the pronouncements from they themselves. Dr. Joel David Tilaksing, consultant in international medicine and diabetes and endocrinology. He works at the San Fernando Teaching Hospital, and he works privately. He's a UB graduate and specialist with specialist training in the United Kingdom. He's passionate about diabetes research. He's a scientific advisor to the Diabetes Association of Trinidad and Tobago, and he hosts live weekly discussions on CNC3 television on public health. The program is called Ask the Doctor. He writes daily columns on the COVID Chronicles in the Guardian newspaper. Dr. Fuad Khan is a former member of parliament who was first elected to the House of Representatives for the constituency of Barataria Samoa in 1995. As a member of the United National Congress. He served there until 2001 and was Deputy Speaker of the House then. He returned to the Parliament in 2010 and served in a similar capacity until 2015. Dr. Khan is a specialist urologist. Dr. Denise Soyafat Angus is a US certified pharmacist and a family medicine specialist trained at the University of Maryland in the USA. She has practiced in the US, in Jamaica, and here in Trinidad and Tobago. She was senior medical advisor in health at the Tobago House of Assembly during the H1N1 era. She lives in Tobago and, among other things, currently is leader of the Innovative Democratic Alliance. A pediatrician for 44 years and counting, Dr. David Bratt is a former senior lecturer in child health at the Eric Williams Medical Sciences Complex at the University of the West Indies in St. Augustine. He's a former head at the Ministry of Health's Control Diarrheal Diseases Oral Rehydration Program. He's the founder of Community Chest Limited, an NGO addressing children in need of open heart surgery. He's been a columnist on health matters in the Guardian newspaper for the past 12 years. Well, just looking at the screen in front of me, I see Dr. Bratt is the one closest to me, according to how the layout is on this setup. So Dr. Bratt, good evening, and can we ask you to go first?
Sure. Mr. Johnson. I was going to say Mr. Andrews, Mr. Johnson.
Yes, good.
First of all, I'd like to thank the National Contract Workers and General Employee Association, of course, for this invitation, and especially their president, Mr. Joe Field, and most especially his assistant, Sherma. So I'm a pediatrician, so I'm going to talk exclusively about vaccination of children using the COVID vaccination, which is up to now, the only one approved for use in Trinidad and Tobago, which is the Pfizer vaccine. And I'm going to talk about that. Now, I want to make just a general statement about vaccinating people and children especially. Anytime that you attempt or you put a foreign substance into somebody's body, especially by injection, you have to be very sure that it does no harm, first of all, and secondarily, that it works in doing what you want it to do, which would be to prevent, in this case, to prevent the COVID disease. In children, that's especially important because children are growing, their cells are growing, and the possibility of causing harm to the growing cells of the body of the child are much greater, first of all, and secondarily, you have a longer time for illness to develop if you give an injection to a 15-year-old as opposed to a 75-year-old, say. So you have to be very careful about what you're doing. So you have to be sure that the advantages of giving the vaccine are there, and you have to be sure about the side effects. Now, side effects I'm going to come to a bit later, but there are two kinds of side effects: immediate and long-term side effects. Immediate happen in the first 6 weeks or so. We can use that as a definition. Long-term side effects happen after 6 weeks. So I just want to say we do not know what the long-term side effects of giving this COVID vaccine is, either to adults or to children, and that should and probably does bother people. What we do know, however, from our experience over the last century with vaccines, is that once 6 months have passed, and after you have given the vaccine, long-term side effects are extremely rare. And up to now, we now have about 6 months experience, or a little bit more, with this vaccine, more in adults, less in children. And so far, we are not seeing any serious long-term side effects. But the potential, of course, does exist. Now, these vaccines, let's go straight to the grain. These vaccines are very, very effective. They're very effective in preventing serious disease, serious COVID disease. I think everybody by now should be aware of this. They are less effective in preventing morbidity, which is illness, but they are still extremely effective in doing that. As far as children are concerned, the vaccine is almost 100% effective. That was the result of the original study, which was done in 1,000 children early on this year, end of last year, beginning of this year. But real life statistics. And for example, in the United States, there have now been over 9 million children vaccinated with the Pfizer vaccine. Real life shows that it's 100% effective in preventing serious disease. Serious disease then means mortality. Or we can look at yes, it means mortality. And the figures are really astounding. All right. In the USA, to give you an idea of, the question really is not whether the vaccine is good. The question is the vaccine needed for children? And there are some people who say yes, and there are some people who say no. The problem is this. In the USA, let's look at mortality for COVID. In the USA, you have a population of 73 million children under the age of 18. Since the epidemic began, there have been 500 deaths. Now, 500 deaths for a population of 70 million really is not nice for those children who died, but really and truly, there have been more deaths in the United States from motor car accidents and suicides and guns and so on than there have been deaths from COVID. So mortality from COVID in the USA is rare. In the United Kingdom, between February last year and March this year, with a population of 12 million children, there were 25 deaths. 25 deaths, really, again, this is sad for those children who died, but this is not something that is way outside the bounds of expectation. These 25 children, for example, 19 of them were severely damaged already. They had life-threatening cardiac, blood, and neurological conditions. In Trinidad and Tobago now, what does the figures show? We have a population of about 250, 270,000 children under the age of 18. There's been one death. And that child who died was a 15-year-old in kidney failure who was waiting for a kidney transplant. Again, very sad, but it just goes to point out that mortality, death from COVID in children the world over is very rare. So then the next step is, what about morbidity? Morbidity is illness. Now you have two kinds of morbidity in general, right? Mild morbidity and serious morbidity. The mild morbidity we know is not a problem. Most children who get COVID are asymptomatic. However, there is a small group of children who get very sick and end up in hospital. I can't give you those figures for hospitalized children in Trinidad and Tobago because our Ministry of Health does not give the medical profession, does not give the pediatricians those figures. I can give you figures for children who have had serious COVID because they have developed what is called the multi-system inflammatory syndrome, which means these children end up in the ICU. Up to the end of August, there were 55 such cases in Trinidad and Tobago. These are critically ill children, really ill children, who are in shock and so on. All of those children have survived, and which is a similar thing that is being seen in the United States of America. Most of the children with this syndrome, which is a very scary thing, which the press likes to exaggerate a bit, but in fact, all of these children survive. Now, in addition to this serious disease, there's something called long COVID, which people haven't been paying much attention to. Long COVID, you continue with the COVID symptoms for up to 2 months and longer. Now, in children, it seems as if about 2% of the children who get COVID, whether it's asymptomatic or mild or severe, 2% of those go on to continue with the same symptoms of COVID. So they are sick for 2 months. Now, in Trinidad and Tobago, what is the figure of how many children do we know have had COVID in Trinidad and Tobago? As of, or again, the end of August, according to the Ministry of Health, it's 3,500 children. 3,500 children in Trinidad and Tobago who have had COVID. So, which would mean if the 2% figure holds up, that we have about 70 children with long COVID. However, again, there is no information from the Ministry of Health as regarding long COVID. And one of the problems right now, of course, is that we have the presence of the Delta virus. And we know that the Delta variant of the COVID is much more aggressive and much more likely to attack children. And we, as of the present moment, we don't have any figures, or at least I don't have any figures. And I spoke to a group of my colleagues with whom I am in contact. They also don't have any figures. So the question then becomes, do we really need a vaccine for children? It's not killing children. The morbidity is not that bad. And a lot of information we don't have. Some would say no. Some would say yes, because it's a question of risk. Do you want your child to end up in hospital? Do you want your child to end up in an ICU? The risk is there, even though it's a small risk. Now, if we look at the opposite side of the picture now, the side effects. I said before, you have two kinds of side effects, the acute and the chronic. The chronic we don't know much about, and we don't think it's a problem. The acute side effect of the Pfizer vaccine is this myocarditis and pericarditis problem, which affects the heart, which immediately is immensely scary. However, children are not dying of myocarditis and pericarditis, neither in the States nor in the United Kingdom, which are the places that have the best figures. How common is myocarditis in children who get the vaccine? Well, first of all, it occurs almost exclusively in males over the age of 60. Secondarily, in the US, and they have given 9 million doses, they have had 400 cases of myocarditis, all survived, which works out to about 1 case of myocarditis for every 20,000 doses. So let's look at the opposite now. How common is myocarditis if you get COVID? And the figure is 1 case for every 2,000 children. So myocarditis from the COVID disease is 10 times as probable that you're going to get COVID. You're going to get myocarditis from the COVID rather than from the vaccine. So these then are the medical figures. These are the medical figures. If on top of all of this, you add the need for schools to open, and we know from what is happening in the States, in the Delta virus, that if you don't immunize children against the COVID, you're going to get a rise in COVID. The schools the children do mobilize, do transmit COVID in the schools. There's an interesting correlation though. It seems as if the people in the community are immunized properly, over 70-80%. And I think in the States right now, they're up to about 70%. I'm not sure, 60-70%. Then the cases of COVID in the schools are less. So that immunizing adults in the community, and we've always said this with children, adults give children COVID by and large. Children rarely give COVID to adults, but children do give COVID to each other in the school situation with this new virus, the Delta variant. So if you add that in to the picture, and if you add into the picture the need for parents to get back to work, then for me, the balance of the evidence comes down on the side of, yes, I think children should be immunized against COVID.
All right, if I may intervene a little bit, Dr. Brad, just to say 2 things quickly. That one is that I'm not seeing Dr. Khan in the frame, which means that he may not show up, and therefore taking into account the time we lost in the beginning, I think everybody, well, the 3 of you on the panel can still have your 15 minutes. As you're coming up on yours, but I just wanted you to speak a little bit, a minute or 2 to the issue about how do you locate COVID-19 and the virus and the vaccines that have been created to treat specifically with it in the context of the history of vaccines and what they have been used for in the past. You talked earlier about, you draw a reference to what has been happening for the last century with developing vaccines. How do you rank and rate and locate the COVID vaccines, all of them, in that scenario?
Well, I have a rather blasé attitude towards vaccinations. I have been vaccinating children, taking into account I started vaccinating children when I was a medical student. It's over 50 years I'm vaccinating children. I vaccinate children every day. For me, it's no big deal. Side effects of vaccines are common, and any mother or father can tell you this. First time you give the baby, especially the DPT, diphtheria, whooping cough, and tetanus vaccine, it's rare for a child not to have a reaction. And the reaction is usually local pain, swelling, fever, crying, and so on and so forth. So I am not at all worried about giving children vaccines. And vaccines have been tremendously useful. We have eliminated polio. We have eliminated we've eliminated smallpox. I don't see meningitis anymore. I don't see measles anymore. I don't see mumps. I don't see whooping cough. I don't see tetanus. All of these things I used to see at the Port of Spain Hospital in the 70s and early 80s. All of that is gone. As I have said before, this new vaccine, there are various types. Some of them, the Sinopharm, for example, is the same old-time vaccine that we've been using all along, the same sort of technique, the same sort of thing. There's nothing new about it, so it doesn't worry me at all. The Astra may be a little more sophisticated, the AstraZeneca, but I don't think that much for it. The new ones now, I understand that people will have some reservations about them, except that when you realize that these new vaccines aren't that new, they're new in the sense that they're just being used, but they have been in development for many years.
All right. I want to ask you to pause there, because it is a question that I had down based on some of what you're saying. We're talking about the history of vaccines, and part of the pushback, if we could call it that, from a lot of people who are so-called anti-vaxxers or vaccine hesitant. I've seen it said that those vaccines that we want to point to, they have been around for a long time. These are just new. But I wanted to put that question in the mix for when we come back to address. But I want to move to the next speaker, and I would say that given the lineup as it is, we should bring in Dr. Denise Soifat-Angus. I'm not seeing you in the mix, but I know I saw you at the start of the program, Dr. Soifat-Angus. Yes. So your turn at the wicket. Good evening. I think you have to unmute your mic.
I want to join by saying, expressing my thanks to the National Contract Workers and General Employees Association for this opportunity to educate the people and make them more aware of what we're dealing with when we consider the COVID-19 pandemic. And so I want to begin perhaps by taking a different angle of it, because Dr. Bratt very eloquently explained a lot of it, and I believe that maybe some persons are more educated as to making the choice for their children. But being a family practice specialist myself, and having perhaps looked at the whole situation of H1N1 and the history of pandemics, I think we have to look at, not just the vaccine, but perhaps also, there's the medical treatment, the education component, the social support, and then also the vaccine, having choice. And so when we look at the pandemic, we think about the medical treatment. And to date, persons have to understand that we really don't have a protocol per se, a wonder pill, something that magically gets persons better when they enter the hospital. And when you're dealing with a pandemic, the issue is really also about testing and doing your best to get ahead of the issue of the spread. And that that needed to be some of the focus, that we had to have in terms of the approach to keeping up and attempting to suppress the spread. And I think to some degree that has kind of gotten out of hand, because I don't think we had enough testing early enough. And that has always been one of the issues that I have found, not having enough testing early enough, and therefore not being able to isolate early enough. Additionally, you look at the education program. I believe we have left persons to some extent to educate themselves on the internet. And when I speak to education, I am not talking about just airways, but also going into communities. We have a number of, when I'm speaking about Tobago, I'm not sure how they're rolling it out in Trinidad, but we have a number of community centers. And I feel that we should be opening the community centers, having our medical personnel there, to answer questions and to meet people face to face in a way that you can explain to them more. Let them feel you. The people are not feeling the medical fraternity. Sitting on the airways, talking to and talking at people will not help the situation to disappear the fear. And I mean, I too was very fearful early on, because you get all kinds of information. And at the end of the day, you have to look at the risk versus the benefit ratio, and then you make a decision. There's something called the placebo effect in the medical fraternity. And if persons are not comfortable going to get a vaccine, then you may see, an untoward effect that you really didn't expect. But just because of their anxiety around it, they will not have a good outcome. And so that is why I'm saying the education program is key. And the education program, not just educating about vaccine, but educating about behavioral modification. Because vaccinated persons do get the disease also. They do get COVID. I have seen I've had family members who were vaccinated who came down with COVID and they still ended up in the hospital. So the issue is also letting people not have a false sense of security over the issue of being vaccinated. And persons ought to know that they need to avoid what they call the 3 C's: closed spaces, crowded spaces, and close contact. And that is why I'm quite confused as to why are we not encouraging people into open air? So we don't encourage them to the beaches, but we say they could go to restaurants, which is a closed area. So I think there has to be a rethinking of the whole approach in terms of opening up. The open air is good for persons being out in the open air, being out in the seawater, being in the sun. It is very good. It's an immune system builder. And I think sometimes we don't pay enough emphasis on building the immune system to sustain whatever occurs. So I really think they ought to rethink that also, that issue of closed spaces versus open spaces, and allowing people to get into open spaces, encouraging that rather than the closed spaces. Of course, being at work, sometimes you cannot avoid it. I mean, one of the things we discovered back with the H1N1 is that the spread was higher when they brought persons into, A&E departments where you had air conditioning units versus persons staying outside with the normal ventilation. And persons did better when they were not in air-conditioned areas, because it was found that the spread would have been more within air-conditioned areas. So it's really lifting persons' awareness and education around all of these things. The behavior modification is a key component, whether you're vaccinated or not vaccinated. It is a key component. And, the social support. I don't think we took into consideration enough of the social support needed, especially when you've discovered a family member who has to be quarantined, or even a whole family to be quarantined. How do you, map? If that person was taken to the hospital and they're being discharged, or the family's being discharged, and they're told they have to go home to quarantine, or they have to pick up medications for the fever, you have that family who may not fully understand. And what they end up doing is they say, oh my gosh, if we're going home to quarantine, we have to pass by the drugstore, we have to pick up this, we have to go in the grocery because we didn't have food, so we have to go get food. They have just created a full spread. And they know they were positive, but they didn't fully understand that they, going into these spaces, that they have increased the spread to others, because their thought is, we have no food at home, we have no medication at home, and we have to go home and stay for the next 14 days. And I think that has contributed to the spread that we have. And I think, again, if we have the education system for people to understand and the social support, then that may help more with the curb of how we treat with the curbing the spread. I want to deal with perhaps this issue of back to school. And whilst we grapple with children going back to school who are vaccinated versus leaving the unvaccinated at home and bringing teachers out, I don't think we have looked at the other piece of it where we're asking persons to come out to work, but who's taking care of the children in that family? Because the preschoolers and the daycares are not open. Sometimes persons may have used their older children to observe the younger ones. They are now back at school. Teachers are now back at school, but daycares are closed and the preschool system is closed. So I think it's also causing a disconnect there. And I believe, as I come from a primary care background, so I believe in looking at the whole picture and not just treating a body part or an issue, because every issue has an impact. And I believe that this whole, we had to look at it as a whole and see the levels of impact and determine how are we going to treat with those levels of impact, because COVID is not going away now. Whether we like it or not, it is not leaving us now. And the faster we begin to learn how to live with it through how we modify our behaviors and how we modify the way we do business in general, that is really how we need to take it forward. And so I think more emphasis has to be placed on that. Now, in persons in a pandemic, and where you want persons to get on board with doing one thing or the other, I don't think you can or should be forcing persons to do anything. I think we have to respect human choice. And we have to understand that if we educate people enough, they would then feel empowered to make the right choice for themselves. But we should never be in a position where we chastise one group for being vaccinated or chastise another group for being unvaccinated. We have to be able to respect personal choice. But the one thing we know in helping people to make choice is if they trust what they're being told. And if there's a level of transparency, and I heard Dr. Pratt talk about the numbers that are not being released even to the medical fraternity. And that creates a sense of mistrust because there's no transparency happening. And when there's a lack of transparency, the level of mistrust increases, and not just, amongst the people, just amongst everyone at all levels. You have a sense of mistrust as to why these numbers are not being released. Why can't we have statistics released across the board, just as how we can sit here and access statistics within the United States or the United Kingdom? Why aren't our numbers being released so that the medical fraternity can make the assessment and they can also then help to educate their patients even more and assist in the fight? And so I think that level of transparency has not been there. And also predictability in a protocol. Sometimes you hear some people are quarantined for 14 days, 21 days, 3 days. I mean, we're in a pandemic. One of the biggest things is that we have to deal with is the fear. And when you have this irregularity occurring in the public domain and unpredictability of the protocols being done, you're shooting yourself in the foot. Because at the end of the day, we wouldn't get any closer to having persons believe what we are saying. And therefore, You may not achieve the goals that you really want, but at the end of the day, I believe that there has to be respect for human choice, for personal choice within all of this.
So you're not in favor of vaccine mandates, if not mask mandates?
I don't believe in the mask mandate. I believe that you have to take responsibility and do the education and believe that at the end of the day, people would make the right choice for themselves. You know, where does it stop? If we are getting into mass vaccination, why aren't we policing people about how they're eating and the way what they're giving their children to eat? Because we know with the current diets that our children are having, we are having a greater we were having greater problems down the road with the chronic with the chronic diseases that we would have, the hypertension, the diabetes. Those are a bigger challenge to us within our society. Yes, COVID is here, but those things cannot be ignored. And if we are saying, mandatory vaccination, why aren't we saying mandatory to the way people eat in terms of them coming down with chronic diseases down the road, non-communicable chronic diseases down the road?
Yeah, and that, a sort of off-the-cuff response could be that, off-the-cuff response could be that because COVID is endangering lives now, not only of those who have it, but those who don't have it, and it's taking lives now. Whereas these things, as difficult as it is to say this, these, you see the effects of it long term. But that is something we could come back to in the opener discussion. I want to thank you very much for your opening statement here, Dr. Soifat. And we're moving directly now to Dr. David Joel Tilaksingh. Your turn at bat, sir. Go ahead.
Thank you very much, Mr. Johnson, and indeed, good evening to one and all. And I would like to thank the administrative team at the National Contract Workers and General Employees Association for their kind invitation. And indeed, so it is a pleasure to be a part of this distinguished panel. And I just wanted to add my voice to what has been said already as we discuss and we trace a history of vaccines. And it has been said that to see the future sometimes is good to look to the past. And vaccines are perhaps the most life-saving tools in the therapeutic armamentarium as we grapple with the scourge of the COVID-19 pandemic. So far, we've seen 4.75 million deaths and 232 million cases. And so if I can just share my screen briefly, there is actually a history with respect to vaccines and in terms of the past. So I don't know if you're seeing this slide here, that the future has a past with respect to vaccines. And just in terms of the general audience, that vaccines actually, and we know that Dr. Bratzer mentioned, it's about the fact that it's mechanisms involving killed or weakened forms of viruses which are injected into the body to stimulate the defenders and soldiers, to stimulate the antibodies, so that if we are exposed in the future, the body will be able to recognize such an invading organism called a pathogen. So in this case, this virus called SARS-CoV-2 is a new member of an old family. So we have had examples of this particular family in the past. In terms of the SARS epidemic in 2003, the Middle Eastern Respiratory Syndrome. And in fact, I was actually reading that more than 100 years ago, if we date back to the 19th century, that it was thought that there was actually a coronavirus epidemic in some parts of the world in which millions of people died. Although we talk about the influenza epidemic in 1918 that killed more than 50 million persons on the heels of World War I. There was actually a coronavirus outbreak too. So it's a new member of an old family. And vaccination itself has a very interesting history from the latter part of the 1700s. There was a physician Jenner, Edward Jenner, who actually scraped pustules from a milkmaid's arm with cowpox. So at the time, and he actually used those scrapings and injected it into the arm. It was a chilling but useful experiment in the end. He injected those scrapings into the arm of a young boy, and it was found that it stimulated him and prevented, of course, but they didn't know exactly what was ongoing, I suppose, at that point. But he did not contract smallpox. Now, if you think vaccine hesitancy is something new, you would be surprised to hear that at that time, when the popular press heard about the injection of the pustules from Jenner, the injection of the pustules from that milkmaid to prevent smallpox, they actually had a lot of cartoons, a lot of anti-vaxxers at the time sharing information saying that, you know, if you took this, cows would actually start to growing out of your hand, and there would be myriad adverse effects associated with this novel form of inoculation. So the whole idea of anti-vaxxers, I mean, when we think about it, we wonder if 100 years ago, if this had occurred, whether or not before the advent of social media, if we would have had so much of vaccine hesitancy. And in the 19th century, Louis Pasteur, who is also one of the doyens in the vaccination era in terms of medicine, Louis Pasteur also did a lot of experiments involving the rabies vaccine out of France. And so over the centuries, so we're talking about the 1700s with Edward Jenner, and those scrapings and pustules actually were utilized by Chinese and Indian doctors as way back as 1000 AD. So although we talk about Edward Jenner as perhaps being the father of modern vaccination and Louis Pasteur continuing his excellent work, that has origins and tracings. And we're talking about a history of vaccination on this first part of a week-long series. And then another landmark with respect to vaccines is one that we all are mandated to receive in childhood, and that is the polio vaccine. And Salk's polio vaccine in the 1950s was greeted with much excitement in the popular press in the United States and indeed globally. And it remains an essential part of the childhood immunization program, which is a national treasure in Trinidad and Tobago, and remains so, as Dr. Bratt was saying, that apart from the administration of vaccines, it's freely available at all health centers nationwide and has virtually eliminated many of these horrific childhood illnesses. Apart from the fact that smallpox has been globally eradicated since 1977, we've seen so many of these childhood illnesses that have been appearing in pockets throughout the world, like measles, in certain areas in which these vaccines are not yet mandated. And the history extends, as we said, from way back into 1000 AD, and across the centuries, there have been many forms of vaccines. The messenger RNA, as we heard about with respect to Pfizer and Moderna, are perhaps novel forms of vaccines in the world. And those are, it utilizes an old form of technology. It's the first time that a vaccine has been utilized for that. However, a lot of anti-vaxxers have spread myths and misconceptions with respect to the adverse effects associated with these mRNA jabs. So the way that these work is that, so I just thought it would be useful to mention that is almost like the old Mission Impossible series, that you inject the vaccine, you get a message, the body reads that message and destroys it. So it's a genetic type of material, and then the body starts making antibodies. It starts assuming that it may have been exposed. It starts to make antibodies against this novel coronavirus, so that if you're exposed in the future, you will have antibodies. So with the plethora of vaccines available locally now, we have 4. And when the vaccination month rolls around, you certainly want to afford yourself an opportunity, particularly if you fall in that high risk category. We've been talking about that, persons with chronic medical illnesses, and those over the age of 60, but now with the arrival of the Delta variant, we're seeing much younger persons being infected with multi-organ disease. It has been said in places like the United States, there are some studies showing that persons who are vaccinated are 8 times less likely to get infected with COVID-19 and 25 times less likely to have symptomatic infection, hospitalization, and death. So the unvaccinated, eventually with highly transmissible variants like Delta, the unvaccinated is probably going to be exposed. And in fact, it's been thought that at some point you are going to get infected, exposed, or protected in some way, bearing in mind that 30% of persons may have no symptoms but may transmit. So you're going to monitor the situation and ensuring that you have access to competent medical care and getting the recommended rest and exercise. I know Dr. Soyafat Angus mentioned about boosting immunity naturally, a healthy diet as well as exercise, avoiding stress, not smoking, limiting alcohol, and avoiding those high-risk, closed, crowded, and close contact settings. We've spoken ad nauseum about the possibility as well of, apart from vaccines, we've spoken ad nauseum about the mitigation strategies with respect to COVID-19, like social distancing, hygiene, ventilation, vaccination. So, and if I can also add about masks, that perhaps we don't speak enough about the fact that these also reduce the transmission of SARS-CoV-2. And there was a study out of Bangladesh that looked at surgical masks against very high quality cloth masks and found that surgical masks reduce spread, but that was not seen with very thick, those were 3-layered cloth masks in Bangladesh. And it was interesting that mandates there in terms of mask wearing were not thought to be useful. However, if they got encouragement from persons whom they trusted, and trusted is the currency in public health. Without trust, you don't have the public health. That is the foundation. And most of the times when we're talking about even vaccines as another step as part of our exit strategy to COVID-19, perhaps I want to echo the fact that if persons have lost trust in the science and some of the decisions that have been made, then you will struggle and you will battle vaccine hesitance even more. And they've seen that in all parts of the world. So Trinidad and Tobago is no exception. This is something globally, apart from the infodemic of myths and misconceptions that we've been bombarded with a stream of misinformation from social media. Persons have to trust the information from reliable authorities, regardless of the messages that we're transmitting. So I want to congratulate and thank the National Contract Workers and General Employees Association for having the foresight to have a series of lectures of this type. We've seen that vaccines are not new. The benefits outweigh the risks when we're talking about it. So I don't think anyone in the panel has been paid to actually speak about the value of vaccines, but despite what some of our persons may think, but the value is there. It goes back centuries when we're talking about some of the mechanisms of action used for vaccines, way back towards 1000 AD, then to Jenner, to Louis Pasteur. We've seen incredible advances. And with respect to mandates, we're not trying to blame school or to force anyone into taking vaccines. And I know Dr. Bratt, my esteemed colleague and writer, we have actually spoken about vaccines with respect to children as we think about the reopening of schools. And if I can actually close my segment by saying that it's mind-boggling that we would speak about reopening restaurants, bars, and cinemas, and keep schools shuttered in a virtual, faltering learning environment. It has been said, and I think that we all agree, that schools should be the first to reopen and the last to close. And they've actually been seeing that schools which have remained open in parts of Europe, like Sweden and Norway, have actually shown that there is not necessarily a marked surge in infections or mortality associated with keeping this essential tool open for our children's future. So I now hand you back to Mr. Johnson.
Thank you very much, Dr. Tilak-Singh. Well, let's open the discussion. Or there's a question on the board here, but I'll come to that in a moment. Let me just post it in any case. if Mr. Any technology has been studied for years, why has it never been approved before? But before we go to that, and I'll throw it out to all three of you, let me just get your take, Dr. Tilak Singh, on the point raised first by Dr. Bratt and then supported by Dr. Soifat Angus, that they, for some reason, and you all may know what the reason is, that enough information has not been, data has been provided to the population over these 18 months of us dealing with this thing. Where are you on that, as to how we might have been better served with more data being presented, if not to the general public, to professionals such as yourselves?
Yes, actually, I wrote on that in the Guardian this morning about the fact that data, especially with respect to deaths, with respect to infection rates, to demographics. Now, I understand that we need to protect patient confidentiality, but that doesn't mean that we can't get information with respect to what happens in ICU in terms of treatments there. What we get in terms of the updates would be with respect to the persons who may die, the numbers of infections, and the number of tests. And we need a little bit more information, something simple like persons have been vaccinated versus the unvaccinated. We know it's been said that the possibility of breakthrough infections is still there, but the chance for death is markedly lower in the unvaccinated person. Of course, we hear many persons saying that the chance for transmission is still there, despite the fact that that I'm unvaccinated. So what's the use I wear my mask? What's the use then that I receive the vaccine? But what we need to actually get an idea as a population is the number of people who have been vaccinated, the numbers hospitalized, those have been admitted into an intensive care setting, if you've been vaccinated, and side effects too. So we need to have some level of transparency and candor with respect to the adverse effects associated with these vaccines. That is something that persons often say that and shared on social media, and that generates a lot of fear and mistrust amongst the general public. Obviously, if you're hearing about someone who could have possibly died, and then after you hear that you didn't really have much of an investigation, the family members are concerned and worried. So once more, it's back to trust with respect to the need for more information out there. This is how we're going to build trust. I don't know how we're going to do it after 18 months. But it certainly will start with baby steps towards the next phase in our pandemic strategy.
Thank you very much. Let's come back to you, Dr. Soifat Angus. And you think there's time for those baby steps to be taken even now? Because I have to tell you that I regard a lot of what you say as being sort of a critique of how this matter has been handled by the authorities over these last 18 months. Is that correct?
Well, yes, and as Dr. Tilak said, it's not just in Trinidad and Tobago, but we live here, and so this is what we have to deal with. And when you have a lack of information, not just to the average person on the street, but even to your medical fraternity who could assist you in this fight, who you need to be able to assist you in this fight, it is challenging. And I feel that I don't know if they fully comprehend the need to build trust in this way, or if it is something that they are so overwhelmed that they overlook it. But either case, they need to start addressing it, because the more information that we have, the more we feel that there's credible information coming forward, the more transparency that we see in terms of how protocols are being rolled out, then is when the trust would build, and you wouldn't have to legislate anything. People will begin to naturally say, okay, I feel that I can trust more, I am more at ease, my anxiety over this whole vaccine issue may be lessened, and persons will eventually make a choice. Again, there will always be persons who will not want to have the vaccine. So you have to be willing to work with persons and build trust throughout this whole issue of the pandemic. Everyone knows that the one thing you say, well, the first thing you say when you have a pandemic, and this is not the first time we've had this, it's always centered around trust and building trust, so you can then influence the people in terms of what, is what you think is best for them.
Yeah, thank you very much. So come to you, Dr. Bratt, again on that issue about what you see as the deficit in releasing information, and put alongside that this question directed to you. You said to have spoken about immunization against COVID, but these so-called vaccines don't immunize against COVID. You can still contract and transmit. And somebody's just asking because they say this is very confusing. Unmute your mic.
Yes, I'd like to congratulate my two younger colleagues on some really good presentations. Joel on that history of vaccines. Denise said so many things with which I agree. Basically, to come back, that educational component, which has two sides of it. One is the information to the medical profession, which has been abysmal. After many, many years, many months, I was finally able to get this document on the 15th of August with the number of cases of children who have had COVID in Trinidad and Tobago. Up to that point, I was depending on my colleagues in Jamaica and in Barbados to tell me how the children were presenting and what I should look forward to, because up to today, there still is no information about that. The other important part is the education of the public. There seems to be a belief that you educate the public by having press conferences. Nothing could be farther from the truth. You can't just sit down in front of a television camera and talk to people. To educate people, you have to have a comprehensive educational campaign, which was done in the 80s with the National Control of Diarrheal Disease Program, the Oral Rehydration Program, when the Ministry of Health, in alliance with McCann Erickson, helped by a gentleman called Dennis Randine, we ran a 6-week multimedia educational program, which told people how to prevent diarrhea, how to treat diarrhea. In very simple terms, 3 points each point, and we hit the people every night on Panorama in those days, on the radio, and with newspaper articles. That was the multimedia part of it. And the second part of it was the personal part of it. We went out to all of the health centers and we gave talks. And when I say us, the team, the nurses and me and other doctors and so on. And we did that for 6 weeks intense, and we got the message over. You have to get the message over. That personal thing is very important. I agree entirely with what Dr. Soyafat said. You have to get involved with people to get their trust. You don't get their trust by standing up on television and talking. Now, to go back to the question was, yes, I think people don't understand how vaccines work. Vaccines never prevent disease 100%. There's not a single vaccine that prevents disease 100%. Let's take the measles vaccine. If you give 100 people a measles vaccine, about 90 to 95 of them are going to develop immunity. 5 to 10% of them are not going to develop immunity. That's because the vaccine is not perfect. That's why we give 2 measles vaccines. If you give the second one, then it goes up to 95 to 98%. But there still is 1 or 2% of people who the vaccine doesn't take. It doesn't take for various reasons, one of which is that that person may be born with an inability to produce an antibody against that particular measles vaccine. This is the same thing with COVID. The COVID vaccine is not perfect. You're going to get breakthroughs. It's expected. So it doesn't mean, even if you get a breakthrough, the breakthrough is not as severe as it would have been if you hadn't taken the vaccine. So for example, when the measles vaccine, you take it, chickenpox vaccine is another one. You may still get chickenpox, but you don't get it as bad, and you don't end up in hospital, and you don't transfer the virus as much. You don't transmit the virus because the viral load that your body is dealing with is not as large because you do have immunity to it. You do kill off thousands and of millions of the viruses. So it helps in the end to reduce transmission.
Yeah, and here's this thing again, an element that is causing confusion. Like, you know, every so often over in succeeding weeks, something comes up that creates more confusion. I'm seeing this coming from the name here is Vinod Mahabir. I'm not sure if he is the Dr. Vinod Mahabir, who's one of my doctors, as you are, Dr. Tilak Singh, and your good friend. He's saying here that I had 2 AstraZeneca vaccines. Can you comment on booster vaccine and how long after should I take it? Because that came into the mix months after we were told that if we got our 2 shots, that was it. If you're taking those, and if you're taking the Johnson & Johnson, you one shot and you go. Now the science is saying, and they tell us trust the science. The science is saying that, well, a booster shot may be necessary for all of us down the road. So we're talking about a 3rd go at it. You want to start with, you want to take that to begin, Dr. Tilak Singh, and I'll come back to you, Drs. Bratton and Sayafat Angus. Dr. Tilak Singh?
It's an excellent question, and it's very much on the front burner when we're speaking about vaccines with respect to this novel virus. And in fact, just last week, the Food and Drug Administration in the United States with the CDC, so actually had a meeting to see whom should be vaccinated and the period of time after the receipt of their 2nd jab. And I think one of the outcomes, it was actually met with a lot of debate and some measure of controversy, because once more, we have good data in terms of that initial 2 shots in reducing symptomatic infection, hospitalization, and death. But the data becomes a bit murky now, 6 months or 9 months since the start of the rollout in the United States. So what they have said, and the director of the CDC has said that for persons over the age of 65 and those with chronic medical conditions that may weaken immunity, persons exposed to high viral loads like frontline healthcare workers, they may want to consider receiving a booster jab. US President Joe Biden had his today, so on the heels of that meeting from the Food and Drug Administration and CDC in the United States. So the evidence, though, is a bit murky for booster jabs, and it has been rolled out in some parts of the world, like in Israel, in the United Arab Emirates, in Bahrain. And definitely, if you had AstraZeneca and you're high-risk persons, like perhaps the chap who sent in the question, our good doctor, it's our same doctor. He is one of the doyens of medicine in East Trinidad. And if that is the case, and you are thought to be at high risk because you're dealing with patients as a frontline healthcare employee, you may benefit from a vaccine 6 months after your 2nd dose. Now, AstraZeneca followed by Pfizer is actually an approved mix by the WHO and locally at the Ministry of Health. That's also another question that some individuals have asked. If you've had AstraZeneca as your 1st jab and you decide that a few months later that you don't want to take a 2nd Astra, whether you can have a Pfizer shot. And studies have shown that vaccines of that type, so Astra followed by Pfizer, actually has a better immune response than 2 AstraZenecas or 2 Pfizer jabs. So I would say that it's something to consider. The issue of vaccine equity in the world is very much up in the World Health Organization, though, that we have billions of people who are still yet to receive 1 shot. And that is where some of the issues exist too. Apart from the fact that the scientific evidence is a bit murky for booster jabs still, we are getting more information. We heard about breakthrough infections. We heard about transmissible variants that are apparently evading the protection afforded by vaccines. But there are still many persons around the world, millions of persons around the globe who are yet to receive 1 jab. And whether or not some of the wealthier first world nations should be sharing their vaccines is something too that has been a very important part as we discuss vaccine equity and even this term vaccine appetite in this pandemic.
Well, thank you very much. Let me come to you, Dr. Sayafat Angus, because this question is a very controversial one, because I think it was around at the beginning, or a year ago or so, that somebody had said that being out and about in the sunshine and so on would have had some kind of positive effect on you. But we knew what happened with that when it came here, because it was said, it was made popularized by the leader of the opposition, and the authorities went to town on that. But to me, in the last couple of weeks, I think Dr. Fauci himself had come back to remind people that there was some element of efficacy for that. And a lady called Cassandra Bernard is bringing that up here and saying that, in fact, being out about and in the sunshine helps to some degree. You want to speak about that, Dr. Soifat Angus, as well as come back to your point about you think it is still necessary for these encounters to be taking place in community centers and places where people gather, rather than, you say, continuing to speak at them and at us rather than with us? Unmute the mic.
The issue is not only access to sunshine, but fresh air. And there is a balance between sunshine and fresh air. Everybody knows in the old days, when you get a flu, when you get the cold, you go to the beach, you take a dip, you feel good when the sunlight hits you because it helps you boost your vitamin D levels. And so it's nothing that we haven't done in the past. Growing up, a grandparents would take you and dunk you and say, take a dip, clear your nose, so this is like a flu. Yes, it's a bit more severe, but it is a flu. And therefore, having access to our natural environment, the sunlight, the ventilation at the beaches, access to the beach, I believe would help us. It would help in taking us out of this social prison. It would help us in boosting our natural, immunity. And I really believe that would have been a great asset. We have it here. Everyone knows that in wintertime, in the other parts of the world, that is when they have the highest spread, because it is cold and they have to remain indoors, and that you get the highest spread there. We have access to the natural environment, sunshine all year round, but yet we are following protocols that are made elsewhere, when we should be developing our own protocols for our own environment, taking advantage of what we have to, what our environment offers to us. And therefore, I also believe, yes, very strongly, that the people have to feel you to trust you. And staying on the airways is not helping the situation. I feel that they have to go into the community centers, but going into the community centers doesn't always, it's not just about assisting you with sharing the information or educating the people, but you're also teaching them. Because when they come in, they know they have to wear masks, they know they, certain feet apart, you put the chairs for them, because even though you say to them on the TV, they may not really comprehend exactly what you mean by space. And so it's also an opportunity to teach them how to gather. And so I feel that is very critical also in terms of going forward. I don't think it's too late, because like I say, we are going to be living with COVID. It is time we start teaching our people how do we live with it.
To what extent you've been saying what you're saying here tonight to others out there and not being listened to or not being taken on?
I've said it. I don't know whether others have taken it on or not. I mean, it's been said. There are plans there in terms of how we treated with H1N1. You can just take it to the next level. But those are things that we would have done before in terms of the education of the people. You have to take it to the people. Especially
Dr. Brad, go ahead.
Our environment. We are very, social people. Our culture is a very social culture. And you have to take it to them in their communities. Put a piece of entertainment in there if you want. But you have to take it to them in their spaces. Meet them where they are. And then take them to the next level.
Dr. Brad, you've been shaking your head.
Yeah, I mean, I am really amazed really at the attitude of our Ministry of Health during the pandemic. They seemed to think that there was no need to meet with people. There was no need to the social part, the feeling, the touching, the actually being there and picking up the body language of the speaker that Dr. Soyafat Angus is talking about is so important in terms of trust. And for that, we need to get outside. You can't do that inside. And again, we have this wonderful environment. We should be encouraging people to go outside. Yes, the weather helps, the sun helps, the breeze helps, ventilation. When you listen to what some of the people away are now talking about, ventilation. One of my Trinidadian friends in Germany during the last winter, in his school, the school computer is computerized, and every 20 minutes the windows would open up so fresh air would get into all of the classrooms. It made the children shiver, yes, but that ventilation is key. We have natural ventilation here. We should be giving school classes outside under the mango tree, as it used to be years ago when I was a young boy living in Pinal. That's where I had my classes. We're not doing a lot of these simple, common sense, practical things. And I think we're paying the price for it.
So this entreated us to trust the science. That's just a slogan.
Well, I think it's been overused. I think it started off well. I think in the first few months of the outbreak, it was being well used. But since then, it just seems to me that they're not following the science.
You mean the authorities?
The authorities, they're not following the science anymore. That is my belief.
All right, thank you very much. Dr. Tilak Singh, here's a question from Geeta Sinanan. She's asking any one of you to inform us on the technology employed in the designing and creation of the different vaccines.
Right. So it's a good question, and we spoke about the fact that the newer types of vaccines from Pfizer and Moderna utilize what is called messenger RNA technology. And I know someone asked earlier about why is it that it's the first time that it's being employed, but the truth is that these vaccines have been the platform using messenger RNA has been around for many years, and vaccines have been made for rabies, the flu, Zika, and another type of virus called Cytomegalovirus. And they were in trials at the start of the COVID-19 pandemic. And some of these actual phases of trials have been published already. So it's the first time, though, that these vaccines are actually being deployed for widespread public use. And perhaps the simplest way of thinking about it, as I mentioned in my opening salvo, that it involves injection of genetic material that tells the body that it sends a message to the body reads it, the cells would read it, and then destroy the message. And the body now starts assuming that these spike proteins on the surface of the virus are present and starts to make antibodies against these spike proteins. Dr. Bratzo mentioned about a Sinopharm vaccine that utilizes a weakened or killed form of the virus. It's impossible to get the COVID-19 infection from these vaccines. But however, the body is able to stimulate an appropriate immune response. The viral vector vaccines involve Johnson & Johnson and AstraZeneca, and those modes involved a modified cold virus from a chimpanzee. The body now recognizes these spike proteins and starts to make antibodies. So the mechanisms may be slightly different, but the goal is to produce antibodies so that if exposed in the future, you would be primed and ready for action. When it comes to novel viruses, and I think a useful saying is that novelty implies severity. If your body is not exposed and ready for something new, then the immune system is going to struggle, and the potential for severe or catastrophic infection is there. And that is perhaps the principle behind all vaccines, that you want to remove the fact that novelty is not going to imply severity at that point. It's not something novel that a body's immune system has been exposed to. So if I can also join the choir in closing, that the great outdoors, and I've written about this to it, Dr. Bratt, who's one of my mentors now, that the great outdoors has never been proven to cause any super spreader event with respect to COVID-19. It is a low risk setting. When we talk about the use of masks when you're exercising, perhaps that makes no sense. So once you're keeping a distance, and beaches, hiking, running, jogging, walking. I understand that they've actually closed the Bamboo Cathedral at Chagaramas on the North Coast Trail because of the numbers of people there. That too is not rooted in science. So especially as we're thinking about following that, which is a mantra that has been said, but as we know, throughout the world has not been followed.
All right, here's this question directed at you. So stay there. And let me just say that I think we could assume we're going to go a little after 9, say about 10 minutes to make up for the fact that we had a late start. I hope that is okay with everybody on the system. But somebody's asking you, Dr. Silak Singh, how can we justify persons with comorbidities taking the chance to be vaccinated and dying when they may have lived a little longer if they had not taken the vaccine in the first place?
So these vaccines have been studied as part of clinical trials, and we know that persons who might be older, they may be obese, they have chronic medical illnesses such as diabetes, high blood pressure, heart disease, kidney failure, they have weaker levels of immunity, so they are more prone to severe COVID-19. And that's why the initial rollout and studies on these vaccines were actually in that population, especially as we discuss vaccines from Pfizer, so Moderna. And at that point, when the virus hadn't had a chance to mutate into different variants, at that point, they had efficacy rates of preventing infection as high as 95%. And many of these trials were actually done on that population. And that's why now that these vaccines have been found to be relatively safe in those persons and the benefits outweigh risks, that they're actually looking at younger persons, at pregnant patients. And those trials have actually been ongoing as we speak. They are ongoing. So if you have chronic medical problems, you're more likely, if you acquire this SARS-CoV-2, you are more likely to be hospitalized, end up on a ventilator and die. And we're talking about unvaccinated persons being 11 times more likely to die. And that specific group is a high-risk category. And that's the reason. Novelty implies severity. So if you're not vaccinated, you don't have antibodies or soldiers to defend you against the onslaught. You are more likely to have catastrophic consequences.
So the taking of the vaccines does not aggravate the comorbidity situation necessarily.
At that point, if you have an infection, you may find that your blood sugar may rise. You may be at an increased risk of heart issues, heart muscle may be inflamed. So the organs actually may be damaged from the virus itself. An example perhaps may be blood clots, and that was very much in the mass media, especially as the first vaccine available was the Oxford AstraZeneca jab. And there was a very small risk of a very rare complication called vaccine-induced thrombotic thrombocytopenia, so in which you had low platelets and blood clots following the vaccine, seen more commonly in younger women, less than 40. Now, it was a very rare adverse effect. The risk of having a blood clot from COVID infection is 16%, but that from the vaccine was 0.0004%. So it's just a matter of actually weighing pros and cons. Everything is about risk, benefits outweighing advantages for everything that we do. Getting in our car and driving, it means we put on our seatbelts. Doesn't mean that you can't get in an accident and even die from an accident. However, it reduces your risk. It reduces the chance of doing so. So that's why you've heard in terms of the mass media, and once more, it's back towards building trust. Why must the public listen to something from mass media, from Facebook or WhatsApp, the public is actually searching and looking for information from somewhere, a source that can be trusted. And that means that they have lost trust in the official sources. So in whatever country, and that may be as a result of months, weeks, or decades of misinformation or the type of information that they have received in the past.
And Dr. Brad, let me put this to you as somebody who, at this stage of the game, the people still consider that we are in the experimental stage about vaccines. And this person is asking, is the breakthrough worth a chance for the population to get vaccinated when it's in the experimental phase?
I disagree
Yes.
that it is in the experimental phase. I think that we are talking now of millions and millions and millions of people who've been vaccinated. And we have real life experience now. We know what the side effects are and we know the efficacy of the vaccine is. So I don't consider that an experiment anymore. You may have talked about it as an experiment when we first started, yes, but I think we have moved past that. And I don't accept that it is an experiment anymore. I think this is something that we should be looking at carefully. We need to continue looking for side effects, especially in children. But I think that we should be moving on with our lives. There was a very interesting article today in the Express by Professor Lewis about looking at football, Premier football on television this weekend and seeing 30,000 people, 40,000 people at the Emirates Stadium, all unmasked, all cheering on the Arsenal to win a game. And this is because all of them are vaccinated and all of them have accepted that we're no longer in an experimental phase. We're moving on. We have to do that in Trinidad now. And as to come back to what Dr. Soyafat Angus said, we have to start regaining the trust of people.
Yeah, and Dr. Soyafat Angus, there's this question from Anna Hospitalis. She's interested in the data and how many children are getting COVID and why are they being forced. So that's two things there. The whole business about the vaccine mandate, which is down for one of these discussions during the course of this week. The question, the pros and cons of what is called the mandate and what's being said about that. But she's saying that yes,
I certainly don't have access to the data in terms of the numbers of children. I don't know if Dr. Bratt would have access to that information in terms of the numbers, but I certainly don't have those numbers. But what I can say is I still believe in personal choice and a comfort with your choice. When you're making that choice, you have to look at the risk versus the benefit ratio. Ask yourself if we can get the data in terms of how many unvaccinated have died versus how many vaccinated have died, how many vaccinated have gotten the side effects and died versus how many vaccinated didn't get the side effects and die. And at the end of the day, we have to be comfortable with making our choice. I want to add also that I have had a number of patients who I have managed at home. And one of the things that I have found is helping them from very early to exercise their lungs. Before this, I didn't realize how much we are shallow breathers, or what I would like to call lazy breathers. We don't take deep breaths. And because we don't exercise those lungs regularly, that too is part of the reason that the COVID just takes a hold of that breathing and causes the difficulty in breathing so quickly. And so there is a tool that I use that I send out to persons. You can look for it. It's called the Zydus, Z-Y-D-U-S Hospital. And it's just a ball that goes around. You're asked to hold your breath and see if you could make it to 10. Normally, regular people make it to 3 until they start practicing and they eventually make it to 10. But it's a good tool to use, especially if you have patients at home and who don't have a pulse, something to check their pulse or the oxygenation levels, that they can use that to see how much their lungs would be compromised. And if they have a baseline, you can see whether it's improving or whether it's getting worse. It's a very good tool. And I always tell my patients, additionally, I'm sorry.
Yeah.
I'm sorry about that. Additionally, that they should be, boosting with vitamin C, D, and zinc. And though that combination in terms of, and also getting outside, walking around in their yard, getting some fresh air, those things are very important. There's no cure, and we have to be able to do some things for ourselves.
All right, and you spoke about this in your opening statement, but here's Kevin Bagaloo trying to expand on it, and he's asking where ventilation is concerned. The Prime Minister is talking about reopening indoor activities such as cinemas, restaurants, and so on, but avoiding opening the beaches. Can either of you please explain why this is, why they're refusing to reopen the beaches, as it's a big open space providing natural ventilation? You spoke to that in your opening, and both you and Dr. Bratt have addressed it.
Yes, and it really, I mean, we perhaps should have done it in the reverse, because open air is much better for us. So we should have opened the beaches first and then done the other parts of it, because the closed environment is more detrimental to us than being in the open air. And if you have beach bars that are outside, that's good. But in terms of the closed facilities, you're really getting into greater risk than if you had opened up the beaches. So I can't explain why they did what they did, but if I were there, I would have done it in the reverse, really, because then it would fit in with the guidelines that says, be careful of the 3 C's. Be careful of the 3 C's.
All right, thank you very much, Dr. Bratt. This is going to be the one to take us out, and it's put to all 3 of you that if all physicians have taken the Hippocratic Oath, then why are doctors divided on the safety and efficacy of the COVID vaccines? The person says no doctor says it's okay to smoke, for example. Open your mic.
Figures for doctors who have taken the vaccine is over 90%. That is a vast majority. Now, if you are asking me that you expect, and I don't see what this has to do with the Hippocratic Oath, because the Hippocratic Oath is something very individual. And there are some things that I would disagree with somebody, in all honesty. So there's no reason for all of us 100%. Again, there's no 100% in anything, Andy. And people just have to accept that. The majority of doctors believe that the vaccine is good, and the majority of doctors are walking the walk and taking the vaccine. So I don't see any problem at all. Yes, there are some doctors. You know, Andy, there are good doctors and there are not so good doctors, and there are a couple of not very good doctors. That's the way life is. That is life. We have to deal with it. Again, we get back to Dr. Soyafat's Angus mention about trust. Go with who you trust and be comfortable in your decision. I think that is the best advice that we can give.
We couldn't have a better closing line on this. My thanks, our thanks to all 3 of you, esteemed gentlemen and lady, Dr. David Bratt, Dr. Denise Soyafat Angus, and Dr. Joel David Tiluxing. Thank you all for making the great start that this week is going to be on this issue. And let me just say that tomorrow evening, the question of the legality of mandatory vaccines in Trinidad and Tobago, that is coming up. And to help us walk through that, attorneys Travis Sinanan and Kurt Waldron, as well as trade unionists Joseph Remy and Mario Alves. Thanks to all of you, ladies and gentlemen. That brings the curtain down on this first segment. See you tomorrow evening.
Thank you for having me.
Okay, good night, everyone. Take care.